Welcome back to Let's Talk About It, a social work podcast, where this season we're exploring the experience of Black veterans within the VA system. I'm your host, Edward Parati-Sousas. In the last two episodes, we laid the foundation for understanding why mistrust runs so deep between Black veterans and the VA system. In episode 1, we began by identifying the problem, identifying the gaps, and how we look to fill those gaps with this podcast. We also introduced the lens in which we'll be examining through in critical race theory, explicitly focusing on Black veterans' lived experiences and centering that expertise as authoritative knowledge. Then, in episode 2, we took a deep dive into history. We traced racism in the United States from slavery to Jim Crow to the present day, and we asked, how does that history show up inside the VA today? Then we talked about structural racism, policies, practices, and beliefs that don't just reflect bias, but create it. And we connected the dots between past and present, showing that mistrust is not irrational. It is memory. It is survival. It is passed down and reinforced in every encounter where Black veterans are not fully believed. Now, in episode 3, we're turning to some of the most personal and painful places where mistrust shows up, in pain care and chronic illness. We're asking questions like, what happens when a Black veteran reports pain but isn't believed? What does it mean to manage chronic illness in a system that has already dismissed our suffering? And finally, what can change? What can veterans do? What can clinicians do? And what can leaders do to begin repairing this breach of trust? Because mistrust doesn't just come out of nowhere. It comes from repeated experiences where pain was doubted, symptoms were minimized, and dignity was overlooked. And nowhere is that more visible than in these areas of care. So why focus this episode on pain and respect? Because pain is invisible. There's no test that can fully capture it. Whether pain is treated seriously depends on whether the person reporting it is treated seriously. And for Black veterans, the evidence is overwhelming. Too often, their pain is underestimated, undertreated, or dismissed. This is not just about discomfort. This is about survival. Research shows that when pain is undertreated, conditions worsen, mental health suffers, and mistrust grows. And as we'll see, this isn't just about treatment. It's about communication, about whether veterans are respected enough to be believed. Respect is the second theme here. Respect is not optional in healthcare. It's foundational. And yet, Black veterans consistently report lower levels of respect in encounters across the VA, whether in routine visits, disability exams, or long-term illness management. Respect is too often missing. And when respect is gone, trust can't grow. Finally, being believed. Again and again, Black veterans say the same thing. I just want to be believed. The plea comes up in pain visits, in mental health treatment, in C&P exams, and in conversations about chronic illness. The pattern is consistent. Disbelief corrodes trust, belief builds it. What this episode will do, it will unfold in 3 parts. First, we'll dive into pain care. We'll explore how historical myths about Black bodies continue to shape pain treatment today. We'll listen to what veterans say about not being believed, and we'll examine what the research shows about disparities in pain management. Second, we'll turn to chronic illness. Conditions like kidney disease, diabetes, and PTSD require ongoing trust. Appointment after appointment, medication after medication, test after test. If trust is low, adherence drops. If mistrust is confirmed, veterans disengage. And Black veterans who already carry higher burdens of chronic illness pay the steepest price when care is not equitable. Finally, we'll close with solutions. We'll ask what can change at 3 levels: the veterans, the clinicians, and the leadership. Veterans have strategies they use to advocate for themselves, but the burden shouldn't fall only on them. Clinicians can validate, explain, and communicate with cultural humility. Leaders can track disparities, allocate resources, and reform policies. Change has to happen at every level if trust is to be rebuilt. Each of these segments build on the foundation of our first 2 episodes. In episode 1, we established trust is not given, it's earned. In episode 2, we showed that mistrust is rooted in history, not just individual encounters. And here in episode 3, we'll show how that mistrust plays out in the most intimate parts of healthcare, in pain, in exams, in illness, and in dignity. Because when veterans say, I want my pain treated, I want to be respected, I want to be believed, they're asking for more than good medicine. They're asking for equity. They're asking for justice. They're asking for care that repairs instead of care that repeats harm. And that's the work of this episode, to shine a light on where trust is broken and to lift up what it would take to repair it. So let's begin. Episode 3, Pain, Respect, and Being Believed. To really understand why pain care for Black veterans looks the way it does today, we need to start with history, because these disparities don't come out of nowhere. They're rooted in centuries of beliefs about Black bodies, beliefs that were created to justify exploitation and that still echo in exam rooms today. Washington in 2006 documents how enslaved Black people were routinely used in medical experiments without anesthesia. Doctors in the 18th and 19th centuries claimed that Black people felt less pain, had thicker skin, or were somehow more tolerant of suffering. These myths were not minor ideas floating around the edges. They were widely taught in medical schools, reinforced by leading physicians, and used to rationalize everything from amputations without anesthetic to gynecological surgeries on enslaved women. One name that often comes up is J. Marion Sims. Sims performed repeated surgeries on enslaved women in the 1800s without anesthesia. His justification was not only that anesthesia was new and risky, but that these women could tolerate pain better because of their race. Washington makes clear that this was not medicine serving people. It was medicine serving slavery. Now, you may think, that was 150 years ago. Surely things have changed. But research shows that these ideas linger. In 2016, Hoffman et al. Published a study where they surveyed white medical students and residents about their beliefs. Shockingly, about half endorsed at least one false belief about biological differences between Black and white people. For example, that Black people's nerve endings were less sensitive, or that their skin was thicker. And here's the kicker. Those who endorse these myths were also more likely to rate Black patients' pain as lower and more likely to recommend less aggressive treatment. This study put numbers into something Black communities have been saying for generations. Disbelief in Black pain is not just in the past. It's present. It's learned in classrooms, reinforced in training, and acted out in clinic rooms. And we don't need to only look at academic studies. Think about how these myths show up in popular culture. The stereotype of the strong Black man or the resilient Black woman often gets framed as a compliment. But in healthcare settings, it means that Black people are expected to endure more before being believed. That expectation can be deadly. These historical beliefs didn't stay in slavery. They carried into Reconstruction, and freed Black men injured from labor or violence were often denied care at underfunded freedmen's hospitals. They carried into Jim Crow, when segregated hospitals offered Black patients fewer options for pain management. And they even carried into the modern opioid era, when studies found that Black patients were less likely to be prescribed opioids for pain. Not because they were a lower risk, but because providers held stereotypes about misuse, exaggeration, or drug seeking. So when a Black veteran today walks into a VA clinic and says, "I'm hurting," they're not just encountering one provider's skepticism. They're standing in the long shadow of history. Every doubtful look, every dismissive comment carries the weight of centuries of disbelief. And this matters for trust. Because if your community has been told for generations that your pain doesn't matter, and then you feel dismissed in your own pain care today, why would you fully trust the system? That's not paranoia, that's memory, that's experience, that's history alive in the present. Now, we've traced where myths about Black pain come from. Let's bring the lens closer to the VA itself, because we don't have to rely only on history or on general population studies. We have data right here on what Black veterans say about their pain care inside VA facilities. And what they say paints a sobering picture. In 2020, Huseman et al. Asked veterans living with chronic pain about their healthcare experience. They found something that should make us all pause. Black veterans were significantly more likely than white veterans to report perceived racial discrimination during pain-related visits. What did that look like? Shorter explanations, providers who seemed rushed, a lack of eye contact, staff who came across as less respectful. And these weren't just annoyances. Veterans who felt discriminated against also reported lower satisfaction with their care and worse ability to manage their pain at home. Bias wasn't just in the air, it was in the outcomes. And Huseman's study wasn't alone. In 2015, Zuckman et al. Dug even deeper into veterans' own words. They interviewed VA patients about their outpatient care. The results? Black veterans consistently reported lower levels of trust in their providers compared to white veterans. And when they explained why, pain was often at the center. Veterans talked about being told, "Your imaging looks fine," as if that meant their pain wasn't real. They described feeling like they had to argue just to be believed. Some said they were denied stronger medication without explanation, or that their pain complaints were brushed aside with, "It's not that bad." These aren't just small slights. They're moments of invalidation that stick. Imagine working up the courage to tell someone about pain you've been living with for years. That kind of dismissal doesn't just affect the appointment, it shapes whether you'll come back, whether you'll open up next time, whether you'll trust the system at all. And we see these patterns repeated in study after study. For example, Jenkins et al. In 2022 interviewed Black veterans with chronic kidney disease. They reported that racism shaped their willingness to talk about symptoms like pain. Some veterans said they prepared for visits by bringing proof, extra documentation, or even having a family member come along to back them up. They felt they had to be on guard, anticipating disbelief. And when that disbelief came, it deepened mistrust not just in one clinician, but in the VA as a whole. Let's sit with that for a moment. Veterans who put their bodies on the line for this country now feel they have to prove their pain to the very system meant to care for them. That's not just bad care, that's betrayal. What's powerful here is that these are not isolated incidents. They're consistent patterns backed up by both quantitative surveys and qualitative interviews. Across multiple VA studies, Black veterans' voices converge on the same theme. My pain is real, but I'm not always believed. And when you put those voices together, what you see is not individual bias. It's systemic, it's patterned, it's structural. And it shows us that history isn't just behind us, it's alive, sitting in the VA exam rooms every single day. When we step back from the VA and look at the national picture, the patterns we see aren't unique to veterans. They're part of a larger story about pain and race in the United States. And that story is remarkably consistent. Black Americans live with more pain, more limitations from pain, but less access to effective treatment. Let's start with the data. The Agency for Healthcare Research and Quality, or AHRQ, publishes the National Healthcare Quality and Disparities Report every year. The 2022 report was blunt. Across condition after condition, racial and ethnic disparities in pain treatment persist. Black patients are less likely than white patients to receive opioids in the emergency room for the same injuries. They are less likely to be referred to pain specialists. And when they do receive treatment, it is often at lower dosages or with fewer explanations of options. Now, some people hear that and think, maybe Black patients are protected from the harms of overprescribing, like the opioid epidemic. But that's a myth. The CDC's 2022 clinical guideline for opioid prescribing made this very clear. Undertreatment of pain is not a protective factor. It's a form of inequity. The goal isn't fewer prescriptions, it's appropriate, individualized care. And if one group is consistently denied adequate treatment, that's not protection. That's discrimination. The burden of pain itself is enormous. According to the CDC's National Center for Health Statistics, as of 2024, about 24% of adults in the US live with chronic pain, and about 8.5% live with high impact pain, pain that limits daily activities and quality of life. Veterans are overrepresented in those numbers because of combat injuries, musculoskeletal wear and tear, and service-connected conditions. And when you break the numbers down by race, the inequities sharpen. Rickard et al. In 2023 published that Black adults report higher rates of pain-related activity limitations compared to white adults, yet remain less likely to receive adequate treatment. That means that Black patients are living with more disabling pain, but with fewer tools to manage it. Imagine carrying a heavier load, but being given fewer supports. That's the daily reality for many Black veterans too. And it doesn't stop with chronic pain. Even at the most serious stages, like cancer and end-of-life care, the disparities hold. In 2023, the National Cancer Institute highlighted research showing that Black and Hispanic patients with advanced cancer were less likely to receive opioid medications for severe pain at the end of life. These are patients for whom clinical guidelines are ambiguous. Opioids are first-line treatment for moderate to severe cancer pain. Yet race still determines who gets relief. If inequities exist at the end of life, when compassion should be paramount, we can be certain they show up in routine care as well. So when Black veterans walk into the VA and report being dismissed in their pain care, they're not describing an isolated VA problem. They're describing something bigger. They're naming a national pattern of equity that cuts across hospitals, clinics, and healthcare systems. And that context matters, because every Black veteran comes into the VA carrying not only their own experiences, but the collective memory of how Black pain has been treated everywhere else. And this is where mistrust deepens, because when the patterns in the VA mirror the patterns in the larger US system, it confirms what many already fear, that their suffering will not be taken seriously, no matter where they go. If there's one theme that runs through almost every study on pain disparities, it's communication. Not just what medication was prescribed, not just what referral was made, but how the conversation happened, whether the veteran felt heard, respected, and believed. The VA Office of Health Equity published an information brief in 2023 that put this front and center. They noted that Black veterans with chronic pain consistently reported lower quality communication in their encounters compared to white veterans. They were less likely to get clear explanations, less likely to be asked follow-up questions, and less likely to be included in shared decision-making. And the brief stressed that this wasn't just bedside manner, it was treatment. Better communication was directly linked to better self-management of pain, stronger adherence to treatment plans, and higher quality of life. VA OHE in 2023. That lines up with the Huseman et al. 2020 study. Black veterans who reported experiences of discrimination during pain visits also reported worse outcomes managing their pain at home. Why? Because when a provider dismisses your pain, you're less likely to trust their instructions. When a clinician doesn't explain the plan, you're less likely to follow it. Communication isn't a side issue. It's the linchpin that determines whether treatment works. Think about the difference between two conversations. In one, a provider says, "Your MRI looks fine, so there's nothing wrong." That veteran leaves feeling dismissed, even humiliated. In another, the provider says, "Your MRI looks normal, but pain doesn't always show up on an image. Let's talk about what else could be causing it and what we can do." That veteran leaves knowing their pain is real and that they have options. The diagnosis hasn't changed. The pain hasn't changed. But the communication has changed everything. Research outside the VA backs this up too. In 2015, a study by Zickman et al. Found that Black veterans explained that their trust in providers depended heavily on how providers talked to them. Being rushed, being cut off, or being met with skepticism all signaled that their pain wasn't valued. But when a provider listened, validated, and explained, trust began to build, even if the treatment itself didn't change much. And communication isn't just about words, it's also about nonverbal signals, eye contact, body language, tone of voice. Veterans pick up on these cues. They know when the provider is really present and when they're not. For those who already carry skepticism from history and from prior experiences, a single dismissive gesture can undo months of effort to build trust. So if the VA wants to address disparities in pain care, it can't stop at prescribing guidelines or referral pathways. It has to get serious about how providers communicate. That means training and cultural humility. That means accountability systems that measure not only pain outcomes but patient experience. And that means naming communication as a treatment in itself. Not an accessory, but a core part of equitable care. Because when a Black veteran says, I want you to treat my pain and treat me like you believe me, what they're really asking for is communication that heals. For many veterans, pain doesn't come alone. It travels with chronic illness, with disability, and with trauma. And when trust is already fragile, the weight of these conditions makes disbelief in pain all the more devastating. Take chronic kidney disease, for example. In 2022, Jenkins et al. Published a study where they interviewed Black veterans with kidney disease. Veterans described how racism shaped their willingness to disclose pain and other symptoms. Some said that they felt the need to prepare for the visit by bringing written notes or even family members to vouch for them because they expected to be doubted. One veteran explained that he braced himself before every appointment, mentally rehearsing how to prove his symptoms were real. That's just not medical preparation. That's psychological armor. And it shows how mistrust seeps into every interaction. If you don't trust that your provider believes you, you are less likely to fully engage in therapy. And when PTSD is paired with chronic pain, a common combination among veterans, the mistrust doubles. Pain makes it harder to sleep, harder to concentrate, harder to cope with trauma. Trauma makes pain harder to manage. It's a cycle that feeds on itself. And then came COVID-19. In 2022, Mathis et al. Published findings showing that Black veterans viewed the pandemic as proof that the healthcare system devalues Black lives. They connected disproportionate COVID deaths in Black communities to their own pain care. One veteran said, "If they let our people die during COVID, why would they care about my pain now?" That's a profound statement. It shows how large-scale inequities fuel mistrust in the smallest of encounters. If you already doubt the system values your life, why would you believe it values your pain? This is the layered reality of chronic illness with Black veterans. Pain is not just physical discomfort. It's a daily negotiation with trust. It's deciding whether to bring up symptoms at all. It's weighing the cost of disclosure against the risk of disbelief. It's preparing for the emotional labor of not being believed. And the stakes are high. Chronic illness like kidney disease, diabetes, and hypertension already carry higher prevalence within the Black communities due to structural inequalities. When those conditions cause pain and the pain is dismissed, the harm compounds. It's not just untreated pain. It's unmanaged illness. It's worsening health. It's deepening mistrust. So when we talk about pain care for Black veterans, we can isolate it from chronic illness and trauma. They're intertwined. And every time disbelief shows up in the exam room, it doesn't just hurt the body. It undermines trust in managing the whole person. So far, we talked about race and pain as if they stand alone. But race never stands alone. It collides with other identities: gender, sexuality, income, disability. And when it does, the weight of the inequity multiplies. We spent this segment talking about history, about mistrust, about how Black veterans' pain is too often dismissed or undertreated. But we can't end here. We also need to talk about solutions, about what can change, because inequities are not inevitable. They are built into systems, and that means they can be dismantled. Solutions begin with taking those voices seriously, not dismissing them as anecdotes, but recognizing them as data, as evidence, and as authoritative knowledge. utilizing the lived expertise of Black veterans to help shape your care moving forward in the future to close equity gaps. So when we ask what needs to change, the answers are right in front of us. Validate pain, explain decisions, hold systems accountable. None of this is optional if trust is the goal. Because in the end, pain care isn't just about relieving symptoms. It's about affirming dignity. It's about showing Black veterans that their suffering matters, that their voices matter, and that the VA can be a place where belief replaces doubt and respect replaces dismissal. When we think about mistrust in the VA, chronic illness is one of the most important places to look, because living with a chronic condition means repeated contact with the healthcare system. It means appointment after appointment, test after test, refill after refill. And if every one of those encounters is shaped by doubt or disrespect, mistrust doesn't just appear, it compounds. For Black veterans, the evidence shows that chronic illness care is a site where inequities are constant, where mistrust is reinforced, and where trust is too often broken. Let's start with the basics. Veterans are more likely than the general population to live with chronic illnesses, things like diabetes, hypertension, heart disease, chronic kidney disease, PTSD, and chronic pain. Some of that comes from age and exposure. Some comes from the physical and psychological toll of service. But here's the key. Black veterans carry a disproportionate burden of these illnesses. Studies have shown higher rates of hypertension, diabetes, and kidney disease among Black veterans compared to white veterans. And they are also most likely to experience multiple chronic conditions at the same time. Jenkins et al. In 2022 interviewed Black veterans with chronic kidney disease. What they found was striking. Veterans described racism shaping not only their experiences of care, but also their willingness to report symptoms. One veteran explained that he only brought up his pain when it was unbearable, because otherwise he felt dismissed. Others said that they rehearsed what they would say before appointments, preparing to prove their case and prove their illness was real. That preparation wasn't about clarity. It was about survival in a system that they didn't trust. Chronic illness and pain are often intertwined. Veterans with kidney disease may also have neuropathy. Veterans with diabetes may live with musculoskeletal pain. Veterans with PTSD often report chronic headaches, back pain, or stomach pain. But here's where trust comes in. If a provider dismisses a veteran's pain, the mistrust spills over into the management of the illness itself. If a Black veteran doesn't feel believed about back pain, why would they trust the same provider to manage their diabetes? If their symptoms are minimized in one area, the doubt colors every other area. And that mistrust has consequences. Veterans may avoid appointments, skip medications, or disengage from treatment plans altogether. The illness worsens, the pain worsens, and mistrust deepens further and further. The disparities in outcomes are clear. Gross et al. In 2021 found that Black veterans had worse outcomes compared to white veterans, even when treatment programs were the same. Part of the reason? Mistrust. Veterans who didn't feel their experiences were validated were less likely to engage fully and less likely to benefit. The same pattern shows up in chronic illness. Black veterans with hypertension or kidney disease are more likely to experience complications, more likely to progress to severe illnesses, and less likely to achieve control over their conditions. The CDC and AHRQ have both reported persistent racial disparities in chronic disease management nationwide, and those patterns show up inside the VA as well. We said this before in the context of pain, but it's even more critical here. Communication is treatment. For chronic illness, where adherence and long-term management are the keys to success, communication is what builds or breaks trust. The VA Office of Health Equity has emphasized that Black veterans report lower satisfaction with communication in chronic illness care. They describe feeling talked over, not included in decisions, or stereotyped as non-compliant, when in fact they were never given full explanations. They also experience longer wait times, less follow-up, and less explanation of the plan. That stereotype that Black patients are less compliant has been documented across healthcare research. But it's a dangerous myth. Often, what gets labeled as noncompliance is really the result of poor communication, lack of trust, or structural barriers like transportation or cost. When providers assume noncompliance instead of asking questions, mistrust continues to grow. And veterans learn quickly that their honesty may not be met with respect. We can't talk about chronic illness without naming the role of structural racism. Chronic conditions don't just come from biology, they come from housing, food access, stress, employment, and environmental exposures. Yerby et al. In 2022 argued that structural racism in housing, employment, and healthcare policy is a root cause of health disparities. That's true in the general population, and it's true for veterans. When Black veterans return home from service to neighborhoods with fewer healthcare resources, fewer grocery stores, and more pollutions, those exposures contribute to chronic illness. So when they come to the VA for care, they're bringing not only the burden of illness, but the weight of structural inequities. If they're met with disbelief or disrespect, the system is doubling down. First failing to prevent illness, then failing to treat it equitably. The COVID-19 pandemic made these inequities painfully visible. Mathis et al. In 2022 interviewed veterans about their perception of care during the pandemic. Black veterans described COVID as proof that the healthcare system did not value Black lives. They connected the disproportionate deaths in Black communities to their own mistrust in VA care. COVID didn't create mistrust, it confirmed it. It showed veterans that their fears were justified. Intersectionality also plays a role here. Black women veterans managing chronic illness often describe facing both racism and sexism in their encounters. Anilny et al. In 2023 showed that everyday discrimination was tied to worse PTSD and depression outcomes among women veterans. Add a chronic illness like diabetes or kidney disease, and the stress multiplies. Pain is dismissed not only through racial stereotyping, but through gender ones, being seen as too emotional or complaining. That's not just a burden, it's a barrier. And for low-income veterans, the economic stress adds another layer. For Black veterans with limited income, that often means heavier reliance on VA services. When those services feel disrespectful or dismissive, the impact is compounded by financial vulnerability. So what can change? The research points to several strategies. First, patient-centered communication. This means not just asking about symptoms, but asking about barriers, transportation, cost, family obligations. It means listening without judgment and recognizing that what looks like noncompliance is often a symptom of inequity. Second, trust-building practices. Validation is key. Saying out loud, your symptoms are real, your illness is real, and your voice matters here can make a difference between engagement and disengagement. The VA OHE brief links validity directly to better outcomes. Third, structural accountability. The GAO's 2023 report made it clear that the VA needs better systems to track equity and outcomes. That applies to chronic illness too. Are Black veterans achieving blood pressure control at the same rate as white veterans? Are diabetes complications being prevented equitably? If not, why not? Without measuring these gaps, they remain hidden. Fourth, culturally responsive care. Training in cultural humility, trauma-informed practice, and intersectional awareness is not optional. It's necessary. Veterans don't come in as one-dimension patients. They bring intersecting identities, and care has to meet them there. Chronic illness care is about repetition, appointment after appointment, test after test. And each of those encounters is a chance to build trust, or break it. For Black veterans, too often those encounters confirm mistrust. Pain is dismissed, symptoms are minimized, voices are unheard. But it doesn't have to be this way. The research tells us what works. Communication that validates, systems that measure equity, providers who listen, and structures that dismantle barriers. Trust isn't built overnight, but it is built encounter by encounter, word by word, gesture by gesture. In our final segment, we'll look at solutions at every level. What can veterans do? What can clinicians do? And what can leaders do to pull the lever of change? Because mistrust may be rational, but it isn't irreversible. We spent this episode talking about pain, about being believed, and about living with chronic illness. And the thread that runs through it all is mistrust. Mistrust built over centuries, reinforced in exam rooms, and felt in everyday lives of Black veterans. But mistrust is not inevitable. It's not permanent. It is the product of systems and encounters. And that means it can be changed. In this final segment, we'll talk about where trust is most often broken and what can be done differently by veterans themselves, by clinicians, and by VA leaders, because change has to happen at every level if we want to move from mistrusting to healing. So where does trust break down? The research and veterans' voices point to three reoccurring sites. First, in pain care. When veterans report pain but are met with skepticism, when their symptoms are dismissed or reframed, trust breaks. We heard this in Huseman et al. 2020, Zickman et al. In 2015. Second, chronic illness care. When veterans with kidney disease, diabetes, or PTSD report symptoms but feel unheard, or when they face structural barriers labeled as noncompliance, trust breaks. That's what Jenkins et al. 2022, Gross et al. 2021, and Mathis et al. In 2022 showed. Each of these breakdowns reinforces the other. A veteran who feels dismissed in pain care walks into a comp and pen exam already wary. A veteran who mistrusts their exam is less likely to trust the same system to manage their diabetes. Mistrust multiplies. What can veterans do? Now, let's be clear, the burden of fixing inequity is not on Black veterans. The system built the mistrust, and the system must repair it. But Black veterans do have strategies they've used to protect themselves and to push for fair treatment. Research shows that Black veterans often engage in what's called extra preparation. In Jenkins et al. 2022, veterans described writing notes, bringing documentation, or even bringing family members to appointments to back them up. While it shouldn't be necessary, it can help ensure that their voices are recorded accurately. Peer support is another powerful tool. The VA Office of Health Equity and other groups have emphasized how veteran peer navigators, or fellow veterans trained to guide others through the system, can build trust where institutions have failed. Veterans often say they trust another veteran before they trust a provider. Programs that harness this can help bridge gaps. And advocacy matters. Black veterans who connect with organizations like the NAACP Veterans Affairs Committee or legal aid groups focused on disability claims often find not just resources, but solidarity. Speaking collectively can amplify voices that are too easily dismissed when isolated. What can clinicians do? The larger burden lies with clinicians. Because trust isn't demanded, it's built, and clinicians hold enormous power to build or break trust in every encounter. So what works? First, explicit validation. The studies showed that veterans respond strongly to hearing their experiences acknowledged, saying your pain is real or your PTSD symptoms are valid. It makes a measurable difference. Second, transparent explanation. The AHRQ 2022 report stressed that disparities shrink when communication is clear. Explaining why certain medications are or aren't prescribed, why a referral is or isn't made, reduces perceptions of bias. Even when veterans disagree, they feel respected when reasons are clear. Also gives them an opportunity to bring things to light that the clinician may not have examined or considered when making that decision. Third, cultural humility and trauma-informed care. A lesson et al. In 2020 showed that Black veterans disengaged from mental health care after feeling stereotyped. Training clinicians to approach encounters with humility, to ask open questions, and to avoid assumptions can counteract this. Trauma-informed care, explaining why certain questions are asked, given choices in pacing, and avoiding re-traumatization, is critical in exams and care. Fourth, accountability at the individual level. Clinicians should seek feedback on their communication. Patient satisfaction surveys, focus groups, or even structured peer observations can highlight gaps. As Huseman et al. 2020 showed us, perceptions of discrimination are not abstract, they're measurable. Clinicians can track and respond to that feedback. What can leaders do? At the highest level, leaders shape the policies and systems that can either reinforce mistrust or repair it. First, data accountability. The GAO's 2023 report made it clear. The VA does not adequately track disparities in disability claims. Leaders must require that data on pain management, exam outcomes, and chronic illness management are collected, broken down by race, gender, and income, and made public. What gets measured gets addressed. Second, resource allocation. Equity requires funding. Leaders must allocate resources to expand programs that work. Peer navigation, culturally tailored communication training, equity audits for disability exams. Without funding, these remain pilot projects instead of systemic solutions. Third, policy reform. Leaders can implement structural changes. Standardized communication scripts for C&P exams, mandatory cultural humility training, and equity benchmarks tied to performance reviews. Policy must have equity not optional but expected, and it is still unclear how DEI removal is going to impact that. Fourth, trust-building initiatives. Leaders can create formal spaces for veterans to share experiences directly with decision makers. Advisory boards led by Black veterans, public listening sessions, and equity task forces that report publicly can all help. Veterans need to see that their voices shape policy, not just fill reports. Why do all of this? Because mistrust is not just an emotion, it's a health determinant. When trust is low, adherence drops, engagement falls, outcomes worsen. When trust is high, even imperfect treatments work better. And for Black veteran, mistrust has been earned. It comes from history, from repeated experiences of dismissal, from inequities that the data confirm. Repairing that mistrust requires action at every level: veteran, clinician, and leader. So where is trust broken? It's broken in pain care when veterans are disbelieved. It's broken in C&P exams where their words are doubted. It's broken in chronic illness care when structural barriers are mislabeled as noncompliance. And how can it be repaired? Veterans can advocate and prepare. Clinicians can validate and explain. Leaders can measure, fund, and reform. Trust cannot be demanded. It must be earned. And it must be earned every day, in every exam room, in every benefits office, in every policy decision. Because at the end of the day, what Black veterans are asking for is not special treatment. They're asking for equity. They're asking for dignity. They're asking to be believed. As we close out this third episode, let's take a moment to reflect on where we've been today. We began with pain care, the front line of trust. We asked, what happens when a Black veteran says, "I am hurting"? And the response is doubt instead of belief. We trace this disbelief back through history, from slavery-era myths about Black bodies feeling less pain, to modern studies showing that bodies still shape how pain is assessed and treated. And we heard what Black veterans say themselves, that being disbelieved in pain care isn't just frustrating, it's wounding. It's a betrayal of dignity. From there, we examined chronic illness. We saw that chronic conditions like kidney disease, diabetes, and PTSD require repeated trust over time, appointment after appointment, refill after refill. And yet, as Jenkins et al. In 2022 showed us, Black veterans often feel they have to rehearse their symptoms in advance, preparing to prove their illness is real. We saw how mistrust in one area, like pain, spills over into mistrust in managing the illness itself. And we heard how the pandemic deepened this mistrust, with Black veterans connecting disproportionate COVID deaths in their communities to their own fears of being undervalued in the healthcare system. Finally, we closed with solutions. We asked, what can change at every level? Veterans can prepare and advocate, though they shouldn't have to carry the burden alone. Clinicians can validate, explain, and practice cultural humility. Leaders can track disparity, allocate resources, and implement policies that make equity a priority. And through it all, the message was clear. Trust cannot be demanded, it must be earned. So what do we carry forward from this episode? First, that pain is not just a symptom, it's a test of belief. Second, that chronic illness magnifies mistrust over time, especially when compounded by racism or inequity. And third, that solutions exist, but they require action at every level. Now, as we prepare for our next episode, we're going to turn the lens even deeper inside the VA, into the claims process itself. We're calling episode 4, Same Diagnosis, Different Decision, Inside Claims. So as you step away from this episode, carry these truths with you. That pain deserves belief, that respect is not optional, and that dignity is not negotiable. Black veterans have carried this truth for generations. The question is whether the VA and the nation are ready to finally live up to it. I'm Edward Parati-Sousis. Thank you for listening. I hope you'll join me for the next conversation, where we step inside the claims process to see how the same diagnosis too often leads to very different decisions. Until then, take care of yourselves, take care of each other, and remember, trust isn't given, it's earned. Make sure you like, follow, and share with a battle buddy who needs to hear this, a peer who can benefit in care delivery to Black veterans, or a leader who can pull a lever of equity. I'll see you in the next episode.